Oh, hi. Good afternoon to everybody. I'm happy to follow up that exciting and activating exercise session. May seem incompatible with sleep, but as I'll talk about in a little while, it's actually very helpful for sleep. It often can be. So I'm happy to talk to you today and give you a little information about what we know about aging and sleep and what happens to sleep as we get older. And I'm happy to take questions. And I think the end, particularly at the end, I think Dr. Parker will moderate that. But I have some slides here to present. First of all, I've been fortunate in my career to have a lot of support from both the National Institutes of Health as well as industry partners and other sources as well. So here's the outline of what I'll be talking about today. I'm going to talk about both what we call subjective and objective changes in sleep. Subjective, I mean what people experience, what they report about their sleep as they get older. Objective, meaning what we observe, particularly when we evaluate and study people in the sleep laboratory. Yes, there's a sleep laboratory in the Brain Health Center. It's on the 4th floor, where we examine people's sleep while they sleep, and that's what we call objective measures of sleep. I want to talk a little bit about the functions of sleep. You know, this is a fascinating topic that still is unsolved, by the way. There are probably a lot of different functions. We'll talk about a few of them. I want to talk about medications and supplements and things that people do to try to help themselves sleep, and give you some also some behavioral approaches that we use that don't involve medications or supplements. And then I want to end with talking about two very specific and relatively common sleep disorders: sleep apnea, which is very common, and then a disorder that maybe you haven't heard of called REM sleep behavior disorder, which is a fascinating condition, not as common as sleep apnea, but a really significant one that we're involved in doing a lot of important work on right here in EP12. So that's the outline of what I'll be talking about today. And Dr. Parker points out, I am an academic and I think about data and research. So I don't want to bore you with a lot of numbers and data. On the other hand, everything that we think about in terms of trying to help people sleep better is based on data. And so I'm going to show you some data slides and try to explain them, though there's no quiz on any of this. This is a slide that shows how common poor sleep is as we get older. Okay, this study was done in Texas many years ago, but there have been studies done all through the U.S., around the world, that show pretty much the same thing. First of all, I want to direct your attention to different age groups, 1 to 6. So on the bottom here, you see all these numbers 1 to 6. So 6 is the oldest age group, 65 and up. And on the y-axis here, this part of the graph is how common, these are percentages, how common disturbed sleep is: 10%, 20, 30, 40%. And the first thing you should see right across from the get-go is that as age goes up, those percentages go up. So the older we get, the more likely we are to have disturbed sleep. As a matter of fact, by the time you're 65, difficulty maintaining sleep, more people have that as a problem than don't have that as a problem. It's really very common. It isn't always something we have to be concerned about, although in some cases it can be. But just to let you know, if you have trouble with sleep and you're over the age of 65, that's very common. It's not an unusual or an atypical thing. There are differences between women and men. Women generally are reporting more disturbed sleep than men, but that's self-report. If we study women and men in the sleep lab, men sleep worse. So there's a breakdown between what the subjective experience is, what people report, and what we see using objective measures. Women generally, at almost every age, in general now, have better sleep than the average man of that age. So those are the only points I want to make from this data-intensive slide, that poor sleep is very common as we get older. Why is that so? What causes it? Why does sleep break down, if you will? There's lots of reasons for it. There's just not one simple reason. And this is, again, a data-intensive table, but I'll just walk you through the numbers. These are all different kinds of risk factors or conditions that people can have. Heart failure, chest pain, COPD, all kinds of back pain, hip pain, and so on. And the numbers over here are the odds. What's the increased likelihood that someone's going to have insomnia? And what you can see is if you have hip pain, you're 2.2 times as likely to have insomnia than if you don't have hip pain. That's how you need this. And you can read all the numbers across here, but generally all these things are contributing to poor sleep. And if you have multiple things, then you have even more reasons why your sleep may break down as you get older. At the top of the list are depression and dysthymia. Dysthymia is a kind of depression that's maybe not full-blown, and those are certainly important ones. But here's the really important thing that I want you to keep in mind. Just because you're sleeping poorly and you're older doesn't mean you're depressed. Okay? If you have pain, you're not going to be sleeping well. That's a whole separate issue. If you have heartburn, you're not going to be sleeping well. Many people make the assumption that if they're not sleeping well as they get older, there must be a psychiatric cause. That can be the case. It's certainly there are important factors, but don't necessarily assume that. Okay, so these are just an overview of some of the many kinds of conditions that impact our health that do affect sleep. One of the most overlooked issues, I think, with what disturbs our sleep is waking up at night to pee. In fact, we did a survey like this a few years ago, and if you look at all of these different factors and you ask people in like a checklist, does this disturb your sleep? Does this disturb your sleep? Are you worried about problems in your family or money or heartburn or cough or even pain? The thing that comes out, the most common reason that sleep is disturbed as people get older is I have to wake up to pee a lot. I'm not telling anyone in this room anything that they don't know. But for a long time, we ignored that. We focused on a lot of other factors, and yet this is a very common one. So it's a particular area of interest of mine. We could talk more about that, but I don't want to get into all of the details. There can also be many reasons why somebody wakes up so often to pee. If you take a diuretic at night, you're going to wake up often to pee. So when we move into the sleep lab, away from the self-report, and we objectively measure sleep, we've learned a lot about brainwave patterns for people as they sleep. And it's kind of a little bit obscure slide, a little hard to see, but I'll point out just a couple of things. We found, look at these brainwaves here. Big, large, what we call delta waves, slow waves. This is the deepest stage of sleep. This is our soundest, deepest sleep. Being this, we tend not to be disturbed by anything, either internal or external. In order to get to this deep sleep, this so-called delta sleep, we pass through stages 1, stage 2, and then we get into delta sleep, which is now called N3 sleep. So there's a progression during the night. We get into deeper and deeper stages of sleep. How about this down here, REM sleep? Does anyone know what that is? I'm sure someone does. Rapid eye movement sleep. You know what that well known for? Dreaming. That's right. We're most likely to dream in this stage of sleep. And interestingly enough, it's not when our brain waves are real big. It's what we call a desynchronized EEG pattern. And that's most common for REM sleep, and that's when dreams occur. Dreams are a fascinating topic. I won't discuss them at all in the whole talk, but if you have questions about, actually, that's not true. I will talk at the very end about dreams when we talk about acting out your dreams. But I'm not going to spend most of my talk about dreams, though. So when we look at the stages of sleep, or what we like to call the sleep architecture, this is what we typically see in a young adult or a healthy middle-aged adult. These are the hours of the night here, sort of beginning maybe around midnight or so, and 1, 2, 3 in the morning till 7 in the morning. And you can see an alternation between the stages of sleep. You're awake at the beginning of the night and you fall asleep and you go down into deep sleep, stages 3 and 4. And then intermittently you have REM sleep, which is the orange line up there during the night. REM occurs intermittently. It doesn't occur all at once. It occurs in REM periods. We call these bouts of REM sleep. This is the typical pattern in a middle-aged adult. In a older adult, it changes. One thing you should see right away is that there's not as much deep sleep. The deep sleep tends to decrease. So the bottom part of this slide shows what happens with aging. Not as much deep sleep. So your deep sleep decreases. And this is normal. There's a normal decrease in the amount of stages 3 and 4, what we now call N3 sleep. Notice also, however, REM sleep continues to persist throughout the night. That doesn't change all that much with normal aging. It turns out in Alzheimer's disease, it does tend to decrease to some degree, but not in normal aging. And the other big change that occurs that we see objectively in the sleep lab is that people wake up more frequently. And that's this alternation here between awake stage 1 and stage 2 that seems to persist all night long, particularly in the second half of the night. So that's the kind of objective measure we have that often corresponds to the insomnia that people talk about as they get older. Okay, if I can have the next slide. So this is N3 sleep, or the deep sleep. Remember the big delta waves that I showed you. This is what happens to that with aging. So this is the percentage of sleep that you spend in deep sleep. So when you're in your 20s, that can be 25, 30%, even more. A third of your time is spent in really deep sleep. That's great when you're young, but as you get older, it begins to decrease. And there are some people by their 60s and 70s that have no deep sleep. And even those that have it have a reduced amount. So this is an objective marker. It's a normal component of aging for the depth of sleep to decrease as we get older. Next slide. Thank you. Let's talk about the functions of sleep. You know, this has been a fascinating topic. And I think if you read that quote at the top of the slide, obviously sleep serves a vital function. But after all these years of studying it, we still don't know exactly what that function is. And so if it does not serve a vital function, it's probably the biggest mistake that evolution has ever made, because we spend maybe a third of our life doing it. Why do we do it? There are all these different theories, and a lot of them are backed up by good data. But I can't say there's only one reason that we sleep. At a simplistic level, if you think about animals in the wild, sleep keeps us out of trouble. You know, if we sleep in a protected environment, a safe environment, we're less likely to have bad things happen to us. I guess that's just true today as it was in the years of the caveman as well. We want to
We want to be safe, and sleep keeps us out of trouble. But there's many other reasons for it. Turns out it also helps us regulate our body temperature. If you take an animal and you don't let them sleep for long periods of time, their body temperature goes out of control. They can't control it anymore. Their body temperature just doesn't work right. There certainly is a lot of fascinating data that our cognitive function depends on good sleep. But, you know, many people sleep lousy for most of their life, and this doesn't necessarily lead to impairment in cognitive function. Dr. Parker mentioned before, yes, there's some very interesting data that sleeping well may be protective for developing Alzheimer's disease and other cognitive problems in late life, but this can't be all of it because there's too many people. Anybody who does shift work, who does chronic shift work for many years, has lousy sleep. And some people tolerate it better than others, but there's many other factors that enter into why cognitive decline might occur. I do want to focus on one particular theory, and if I can have just advance one click, thank you. And that's this here called lymphatic drainage. Now, it's a fancy word, and I'll just explain a little bit about what this means because it's become a very popular and sort of easy to understand theory as to what happens with sleep and why sleep occurs. If I can have the next slide. This was a famous paper that came out just about 10 years ago now that showed data that supported this theory. The notion is that sleep is a time when the brain drains itself of unwanted metabolites. Okay, that's the concept. It's called lymphatic drainage. And if I can have the next slide, it all begins with the concept of glia. Has anyone ever heard of glia in any of your talks here? You've heard about it. I see some heads shaking. Glia are cells that support neurons, that support nerve cells. So you have nerve cells in your brain, neurons, but the scaffolding that helps the neuron, that feeds the neuron, that gives the neuron energy are called glial cells. And the theory has been, and this important paper that I just showed you a second ago from Science showed that the glial cells seem to activate during sleep. They help drain the wastes and the metabolites that may be occurring in the neurons, in the nerve cells in the brain. And so this has become one of the more popular, not the only theory, but one of the most popular theories as to why sleep takes place. If I can have the next slide. So it turns out that this lymphatic system, we all know about our lymphatic system, but the brain has its own lymphatic system. And we combine that with the word glia to call it a glymphatic system. And that's how the brain drains itself. And if I can have the next slide, I'm just going to go through this very quickly. This was all worked out using animals, using rats. Yeah, do rats sleep like humans? Not exactly, but close enough for us to manipulate their brains to look at what we think happens in humans. And it turns out that if you inject a dye in the brain of an animal while they're asleep, if I can have the next slide, what you see is there's an active transport over the period of 10 to 20 minutes if the animal is asleep. So the brain is actively transporting these waste products, in this case, a dye that was put in the brain. It actively transports it. It's not diffusion. It's not like you would drop some ink in a tub of water and watch it diffuse in a very slow manner. This is active. Over a period of 10 minutes, you begin to see, only during sleep this occurs, you see this active drainage. And this is the lymphatic theory of one of the functions of sleep. So I'm not going to talk about this anymore. I just want to give you some sense that this is when we talk about how sleep may be important for brain function and cognitive function, this is part of it. The waste products that build up in the brain can be drained through a system like this, if I can have the next slide. So let's focus now. The rest of my talk will be on more clinical topics. I did need to give you a little bit of the basic science background because that's how we've learned a lot about sleep over the years. And so what happens when we can't sleep and what do we do or try to do when we can't sleep? Okay, let's go to the next slide. So this table gives you all of the medications that are currently approved as sleeping pills by the US FDA. There's a lot of them, yeah, a lot of them. And maybe some of you have experienced some of these. I sort of divide them into different colors here based on sort of the age and how old they are. This is the first generation of sleep medications. They're called benzodiazepines, and they've been around a long time. These are other medications that are related to benzodiazepines, but not exactly. Zolpidem has the trade name of Ambien. You've probably all heard of that at least some point. There are other ones. There's a melatonin agonist. There are 3 newer ones down here. These are the newest kids on the block, and they work with a very different mechanism. They're called orexin antagonists. They work in a different brain peptide system. But all of these medications have been shown to be effective for sleep. I'm not touting all of these medications. I'm not telling you you should or shouldn't take them, but I want to let you know there's an awful lot of them that are out there. Some important other distinctions to make between them is how long, what we call how long their half-life is. That's how long they stay in your blood after you take them. At the shortest end, there are medications where you take them and within an hour or 2, they're gone. So they're only effective for a very short time to keep you asleep. There are other medications, particularly some of the older ones, that can stick around for 3 or 4 days after one single dose. So obviously, depending on what you're doing during the day, how active you are, whether you're driving a car, operating machinery or equipment, you have to be very careful with medications that have a longer half-life. And so that's part of the balance and concern that we always have when prescribing these drugs is when is the person taking it? What are they doing the next day? Because you can be hungover from some of these drugs. If I can have the next slide. What are the risks and what are the benefits? Let's start on the green side here. They usually work, at least for a little while. Most of these drugs, if you take them every single night, become less effective over time. It's hard to say what that time base is. And for some people, it's less than a week. The drug's less effective on the 5th or 6th night than it was on the first night. Some people can take these drugs every night for a year, and they remain effective for them. So they usually work at least for a little while. They're a better option than some of the dietary supplements, and we'll talk about those in just a second. That's a very important point. I talked about the different half-life, and yeah, we believe they're probably more effective and better than some of the low-dose antidepressant medications. So drugs like mirtazapine or amitriptyline, which is an old-time antidepressant, even a medication like trazodone. These are antidepressants that are sometimes used to help people sleep. Most of the studies show they're not really as effective for sleep as those other medications that I showed you just before. What are the risks? Tolerance can build. That's what I mean when I say the drug becomes less effective over time. You develop a tolerance to it. Taking the same pill every night, all of a sudden it doesn't work anymore. Gee, it worked great for a while, but it may not work every single night. And so we often, when we use these medications, tell people to take it every third or fourth night. Yeah, you go through a night or two of bad sleep, but then you can take the pill. If you take it every night, you build up a tolerance. One of the biggest concerns, I know that Dr. Parker would be very concerned about this with these medications, are problems with balance and falls. So sedative hypnotic use, which is what we call this class of drugs, is associated with falls. And if you remember what I showed you that slide with people waking up to pee so often at night, if you're waking up 3, 4, 5 times a night to go use the bathroom and you're taking a medication like this, you're more unstable on your feet. Some of the medications tend to be worse than others, and I won't get into all the details of that. There are certain classes of that big table that I showed you that are more likely to produce falls than others. But this remains a major concern, and many geriatricians don't like to use these medications because of the risk of falls. There have been some odd behaviors that have been reported. People getting in cars and driving to the store after they take a sleeping pill. I have to tell you, in my experience, those are pretty rare. And most people, if you're going to use this medication, this type of medication, we tell you take it as you're ready to turn off the light. Don't take it. I've had patients take sleep medication at 7 p.m., even though they're not going to bed until 10:30. And I said, why do you do that? And they're used to taking their evening medicines. Sleeping pills don't work like that. They're absorbed quickly. You take them when you're about ready to go to sleep. So some of the odd behaviors that have been talked about may have something to do with that. And there are some data, if you look at the internet, you'll find some suggestion that sedative hypnotic medications may have a higher association with cancer. Those data are pretty rare, and they're not really as big a concern, for example, as falls. The falls data are much more relevant and important, I think, than these studies, but these would, of course, get a lot of press. I could have the next slide. So let's talk about supplements. Okay, how many of you don't have to answer this, but have ever tried melatonin or know someone who's tried it? Yeah, a lot of people, a lot of people. So melatonin is a dietary supplement. It's not a medication. You don't need a prescription. You can buy it in a health food store. You can buy it in Costco. You can buy it in Publix. And there's actually evidence that it can be effective for sleep. And so these are a couple of the papers that came out in recent years that systematically examined the effects of melatonin to show that it helps people sleep. If I could have the next slide, please. However, because melatonin is unregulated, you don't really quite know what you're buying when you buy it. So this was a fascinating study that was actually comes out of Canada. They went into health food stores and they just bought melatonin off the shelf, different brands. And they looked at what the dose said, and then they analyzed, using biochemical techniques, they analyzed the concentration of those pills for melatonin. And here, look at these numbers down here. According to what the label said, the variation could be from minus 63% to positive 478%. So if you bought a 1 milligram tablet of melatonin off the shelf, it could contain 0.63 of a milligram, less, almost a half of a milligram, or it could contain almost 5 milligrams, even though it's labeled a 1 milligram tablet. Why does that happen? It happens because dietary supplements are not regulated in the United States, or in Canada for that matter. There are certain places in Europe that have a little more constraints over the labeling. They're not controlled by the Food and Drug Administration as medications. They're considered supplements, dietary supplements. So melatonin, if I can have the next slide, may be your friend, it may be helpful, but like anything, buyer beware, be careful. Once you find a brand, if it works for you, stick with that brand. Don't switch out, don't switch the strengths, stick with that brand. It may not be consistent over a period of months to years, but it's more likely to be. So there have been concerns. This was in JAMA from a few years ago, that melatonin, a lot of the melatonin that one buys may not necessarily be as safe as we think it is. So I'm not trying to scare you with this, but I think you have to be aware, if I can have the next slide, that supplements, dietary supplements that we buy contain all kinds of things that we don't necessarily know about. So, in our sleep clinic, we will recommend occasionally patients try melatonin. We have a couple of brands that we sort of seem to have better success with, but be aware of that. And this is true actually for all supplements that you take. Any kind of supplement you buy in a health food store, the products, because of the labeling claims, may not contain everything that you want them to, and may contain things that you don't want to be in there. Okay, next slide. This basically just repeats what I just said, that dietary supplements fall under food law rather than drug law. Okay, if I can have, let's talk non-medication, non-supplements. What are the things that we try to do to help people sleep better? And here your exercise man is I'm going to tip my hat to him, because we're going to come back to some of the stuff he was talking about. When we think of insomnia, when we think of poor sleep, we generally think of three different factors that make someone sleep poorly. Some people are predisposed to bad sleep. From childhood on, they slept poorly. We know this occurs from studies of twins. Identical twins have a much closer relationship in terms of how they sleep than fraternal twins do. And some people from childhood on have had problems with sleep. So this just means you're predisposed. Some people have a low predisposition, some people have a very high one. Factor one. Factor two, there are precipitating factors. This can take all forms. It can take the form of an illness. It can take the form of a stressor, loss of a spouse, loss of a job, travel across time zones. It can be a trigger of some kind of some event that leads to the person sleeping poorly. So the concept is, even though you may be predisposed, there can also be precipitating factors that flip the switch, if you will, and create a poor sleep situation for you. Finally, there are factors that perpetuate or sustain the poor sleep. And we talk about behavioral interventions to help people sleep better. We're often focusing on this circle over here. We can't do too much about this. This may have already occurred, but often people keep doing things that are not conducive to sleep. Like what? For example, okay, they spend too much time in bed. We see this all the time. Someone's getting 5 or 6 hours of sleep, but they may be spending 8 or 9 hours in bed. And you ask them why. Why are you spending all that time in bed if you can't sleep? And they say, well, I can't sleep. I have to try to get to sleep. And part of how we approach that treatment is to get them to spend less time in bed. Every hour you're spending in bed not asleep, it makes it less conducive for you to sleep when you get into bed. So that's a whole sort of behavioral approach that we take often. And what happens is you become conditioned to being in bed and not being able to sleep. So we try to have people spend a little less time in bed. I'll come back and I'll talk about that in just a minute. Voke, I have the next slide. Yeah. So here are some of our behavioral principles that we use for treating factors that perpetuate the insomnia. We can't do much about the predisposing factors or the factors that precipitated it. But first of all, you need a comfortable room. If it's noisy, if it's not dark, you have too much street light coming in, or you sleep with a lamp on or a television on. A lot of people sleep with the television on or try to. We don't recommend that. Even though, and I've heard it many times, an older person will tell me, I live alone, it's comforting to have the noise on. It may be, but it also, noise and light disrupt sleep. So we're not big fans of doing that, okay? Obviously, if you're drinking coffee, tea at night that has some caffeine to it, that's not going to be helpful for your sleep. We often have people do relaxation exercises, not exercise like you just did, but deep breathing. Deep breathing actually helps sleep. If you've ever listened to someone or watched someone fall asleep, you can tell when they're going to fall asleep because their breathing becomes regular. That means sleep is on its way. And so we can give people breathing exercises to help them. This rule that I mentioned before, if you're not sleeping, if you're laying in bed, tossing and turning, thinking about everything under the sun, except you're not able to sleep, get out of bed. Don't spend time in bed then. Go in the other room, do something else, read a little bit. I wouldn't necessarily say get on the internet because you might read something that gets you upset on the internet, but some light activity to do. And then maybe after a half hour, 45 minutes, try to go back to bed and see if you can sleep. That's an important approach. Again, not spending too much time in bed, napping. Okay, I get it. The most common question I get, and I may even get this at this talk, so I'll preempt it now and answer it. Is it okay to nap? I'm older now. I'm retired. I have more time on my hands. Is it okay to nap? It's an easy question to ask, but a difficult one to answer. Now, there's nothing necessarily wrong with napping, but if you're not sleeping at night and you're napping for an hour in the afternoon, guess what? You're using up gas in the tank. Okay, that's the only analogy, that's the most accurate analogy that I can use. If you use it up during the day, your drive to sleep will be less at night. So napping for someone who has poor sleep at night is not a good thing. If your sleep is not impaired at night and you just played a round of golf or you've done some exercise and you're strenuous, you're tired because of the strenuous activity, yeah, a nap is a rewarding thing. And people do function better after they nap. There have been many studies that shown that cognitive performance gets a little lift after you've had dozed for a little bit. So napping is complicated. Sometimes people nap because they have sleep apnea. Excuse me, I'll talk about that at the end of my talk. That's a specific disorder of sleep. So I can't just say napping is good or napping is bad. But when we talk to somebody with poor sleep at night, we always ask about that. And then last but not least, daytime light exposure and physical activity. I can't tell you the number of studies. I actually can. There's been over 20 studies that have shown that physical activity during the day, even in people in your age range, helps promote sleep. As a matter of fact, in nursing homes, they've done studies where people who are wheelchair bound, okay, if they get them work in the wheelchairs more during the day, they sleep better at night. So any degree of physical activity during the day helps promote sleep that night. Ideally, you combine that with getting a little outdoor light exposure, some sunlight. Now, today's kind of a cloudy day and we have a big storm coming through. So don't go out and stand in the rain out there. But physical activity outdoors, a light walk, is very good for sleep. And many studies have shown that both physical activity and even just bright light alone can promote sleep. So these are some of the behavioral approaches that we try to take in the sleep center to help people sleep better, not using supplements and not using medications. Okay, next slide. I think I'm going to bypass this slide. Go ahead and we're going to talk now about some specific disorders of sleep. I'm going to mention two that have gotten some press, and they're probably on your minds to some degree, so we'll talk about those. Okay, so sleep disorders encompasses a wide range of problems, and we've been talking about insomnia down here. We're going to talk now about sleep apnea up there, and we're going to talk about what we call parasomnias, which are unusual behaviors occurring during sleep. But sleep medicine, and we have a sleep center here at Emory where we have expertise that cuts across all these different areas, from neurology and psychiatry to internal medicine. We have geriatricians, we have ENT docs, we have pediatricians. We're not going to talk about that so much in this talk. But sleep disorders encompasses a very broad range of medical specialties. And we're fortunate here at Emory because we do have a lot of expertise that cuts across all these different areas. If I can have the next slide. Let's talk about sleep apnea. Who hasn't heard of sleep apnea? No one's going to raise their hand. Everyone's heard of it. Everyone knows it's a common disorder of sleep. Maybe you have it, maybe your spouse has it, maybe you know someone who has it. So let's talk about it some, if I can have the next slide. What is it? Apnea means absence of breathing. Sleep means absence of breathing occurs when you fall asleep. Your breathing is normal when you're awake. There's no problem breathing when you're wide awake, when you're sitting in a room, when you're watching television. You don't have any trouble breathing. But when you fall asleep, your breathing becomes impaired. And so you see these flat lines here. And what you see is the oxygen saturation. You probably, when you go to the doctor, will get that little pulse oximeter on your finger. You see that begins to fall because all this time here, 10, 20, 30 seconds have gone by and your breathing stops and your oxygen falls. And then you wake up, you often gasp or snort. So gasping for breath is a common sign for sleep apnea. You take a large breath, you see the breaths here, your oxygen goes back up, and then this cycle can continue on and on all night long. If I can have the next slide. So what we do in the sleep lab, we can actually do this with home tests as well. You don't even have to come into the sleep lab to be diagnosed with sleep apnea anymore, is we count the number of times your breathing stops. And we adjust that per hour of sleep, and that's called the apnea hypopnea index, the AHI. It's the number of pauses in breathing per hour of sleep. And that becomes the critical number, the critical metric that we look at to decide, is this a condition that we need to treat? Is this fall outside of normal range? Is this of concern to us that the person's medical status may be impacted by sleep apnea? And this is the major outcome, if you will, that we get when we do the sleep test, be it an in-lab test or an at-home test. If I can have the next slide. Sleep apnea tends to increase with age. So the prevalence of the condition, again, going back to some data here on the y-axis, as we get older, the prevalence tends to increase. It's not unusual by the time you're age 75 or 80, you know, prevalence is almost a quarter of the population has some element of apnea. You have the next slide. In younger people, not in older people, but in younger people, body weight's a big factor. We used to think that sleep apnea only occurred as people were in massively obese people. And that's certainly true in younger people. But as you get older, this is the effect of body weight as a function of age. As we get older, being overweight is less of a risk factor. So now, remember, I just told you the prevalence is increasing, but the impact of body weight isn't as great. That means there's other factors as we get older that impact the presence of sleep apnea. What are those factors? Muscular strength is one of them. Just like we lose muscle mass in our body all over as we get older, we lose muscle strength in our airways, and our airways tend to flop more. And so that is conducive to a blockage of airflow during sleep. I can have the next slide. So how do we treat it? You probably know someone who has a CPAP machine. Continuous positive air pressure, CPAP, is a type of treatment. It's a mainstay of treatment. We have over 10,000 patients in our sleep clinic in this building who use CPAP. It works pretty well. In order to make it work, you wear a mask and you blow air through the mask, and it keeps your airway open. It's like a pneumatic splint. It's an air splint. It keeps the airway open by splinting it open with air. It's that simple. It works when you use it. If you don't use it one night, your sleep apnea is coming back. If I can have the next slide. You may have heard a couple of years ago, one of the major companies that made CPAP machines had a recall. And this created a lot of problems and a lot of hassle. They had a malfunction with their machines. And so they had millions and millions of these machines worldwide, not just in the US, worldwide, that had to be recalled. They've all been recalled now. And if you know someone who still has an old machine, have them come to see us. We can try to get them a new machine. But they kept track of everyone who got these. And if you had come to the sleep clinic, we gave you the information to get a new machine. So that problem is now gone. The companies that make the CPAP machines are now reliable. We, again, have thousands of patients who use them, and they're helpful. But if you've heard about this, this is not a reason to forego treatment. It's a reason not to use this kind of machine. Okay, next slide. There are non-CPAP treatments that work. One is called a mandibular advancement device. This is not connected to an air blower. It's a mouth guard, essentially a mouth guard. It's a little more sophisticated than that. You wear it when you go to sleep. It repositions slightly your lower jaw, so it creates a larger airspace in the back of your throat. And we have many, many patients in this clinic who use oral appliance therapy, which is what we call this. It's a successful treatment. Some people like it more than CPAP. It's finicky in that you have to go to a dentist multiple times to get it fit just right. Because if it doesn't fit right in your mouth, it doesn't feel good. The CPAP machine is easy. You put on the mask and it blows air. But this may work better for some folks. Next slide, please. Now, if you're watching TV these days, you've seen these ads of people throwing away CPAP masks. Has anyone seen those ads? Yeah, right. This is called Inspire. Inspire, they don't tell you this on the ad, is a surgical treatment in which a stimulator is implanted right beneath your collarbone. And what this does is it stimulates the muscles in your airway when you go to sleep. So it's not blowing air. It's not repositioning your jaw. It's actually stimulating. You take a magnet and turn this on at night, and it stimulates your airway and keeps it tight. In the morning, you turn it off. Yeah, it's a big deal. It's a big deal. They don't quite tell you that on the commercials, but that's what it is. It's called Inspire. And yes, we have a very talented surgeon at Emory who does this. And if this is a kind of treatment one would be interested in, we could certainly recommend that you talk to him. If I can have the next slide. Now, I'm going to end my talk with a different kind of sleep disorder that you may or may not have heard of. And this is a fascinating disorder. Remember, I said I was come back to dreaming. Okay. This is where people act out their dreams. We call it REM sleep behavior disorder, RBD for short. It happens when people go into REM sleep, but when they think about having a dream, behaviorally, instead of being quiet and relaxed, they actually start to act out their dream. And if I can have the next slide, and if we can click on this, there's no sound with this. Oh, no. Can we get that to work? I hope we can get it to work because I want you to see what the videos look like. Oh no, can't get it to work. Even if you just, oh, how about that? No. Okay, well, this is a condition where people thrash their arms, they holler out at night, they kick their legs, and they act out their dreams. And it's a fascinating condition that we've learned a lot about here at Emory.